Hello and good evening. My name is Dr. Jason Barker. I'm a clinical lab educator here at Vibrant, and tonight we're going to talk about healthy hormones and balanced aging. So I've got a pretty wide-ranging discussion for us tonight. We're, of course, going to talk about hormones and how we can utilize measuring to help promote healthy aging in our clients and patients. So that being said, topics we're going to look at the what and why of hormone testing, which test we want to use and for what reason, things like balancing for longevity, what symptoms somebody has, why you would want to use a certain test. And then I'll have a few spotlights, key issues, and how to assess risk using some of the markers on these tests. And then, of course, any good lecture on healthy aging would be incomplete without talking about some cardiometabolic points too. So we're going to dive into a little bit of cardio health as well. That being said, let's get started. So this first picture I've got is, of course, a graphical representation of steroidogenic pathway, looking at all the main families of hormones that we're most likely going to be interested in when we're pursuing healthy aging. Of course, progestogens, androgens, estrogens, glucocorticoids, mineralocorticoids, of course, coming out of the adrenal gland. And then, of course, don't forget the thyroid hormones and insulin, also very important in the healthy aging process. Now, other thing to take away from this is that you can see all of our hormones emanate from cholesterol. So keep that in mind. And then the other thing to keep in mind too is, again, this is just a picture. So this is a graphical representation of all these steroid hormone production, but all this is going on at once in multiple different compartments in the body. So they're not as linear as it may appear on this particular picture. Okay, so what are the three methods that we can use to measure hormones? Of course, we have serum, saliva, and urinary methods for testing all these different hormones. Now, serum, I kind of think it's great for just static measurements of hormones, kind of what you see is what you get. Saliva, I always kind of think of that as like, the best for functional measurement. We're seeing that unconjugated pool of hormones that has left the tissue, and we've captured it in the saliva. And then, you could say the same about urine, but really urine is great for the end results of hormones. So we're, of course, going to measure those parent hormones and then also their metabolites. So we can see this is the best test for assessing a person's risk from their hormones. Are their hormones being metabolized healthily, or are they going down the wrong pathway, so to speak? So that's an excellent test for that. Now, I like to use all of these tests. I often use a combination of these tests in my practice. There are many reasons for that, and I'll try and help line some of that out while we're talking tonight. Okay, so let's start in on serum testing. So, it's real time. I've kind of, like I said, it's what you see is what you get. We're looking at those protein-bound hormones that are floating around in the bloodstream. We're getting absolute value. So I kind of think of this as like, is the tank full or empty, especially when it comes to things like thyroid hormone or testosterone, is it high or is it low? And that's often, a very adequate measurement for us to help adjust those hormone levels in particular. Now, again, certain hormones are very definitive, like follicle stimulating hormone, luteinizing hormone, prolactin. These are great for also coming up with specific diagnosis, if we're worried about fertility, or is this woman in menopause, et cetera, et cetera. So serum is excellent for direct measurement and disease or condition assessment in that regard. Now, when you run a serum hormone test with us, you're going to get this page that shows you all the different ranges. And again, like I said, it's what you see is what you get. But of course, there are going to be different ranges, especially depending on, the time of a woman's menstrual cycle. We're going to tell you where those hormones should be in regard to follicular phase, ovulatory phase, luteal phase, even pregnancy, et cetera. And then FSH and LH are, of course, helpful for determining fertility. And also, maybe you've got a patient who hasn't had a period in 10 months or something like that, and you want to see, is she actually in menopause or is she not? Is it just still perimenopause? That FSH and LH can help you with that one. All right. These are all the hormones that you'll see on a serum hormone panel. So again, estrogen, progesterone, excellent for like testosterone, sex hormone binding globulin. Many of these hormones on here need to be measured in serum. we're not going to be using a saliva test or urine test to look at thyroid hormones. It's just not how it's done. So serum hormones, kind of the oldest hormone, the oldest way to measure hormones out there, but still extremely valid for looking at specific hormones that are going to be important to you and your clients and patients in your practice. Now, so some ideal uses for serum testing, direct monitoring, like I mentioned, thyroid hormones. This is how you're going to assess a person's thyroid balance, so to speak. Testosterone. I prefer using serum testing for testosterone because I can also look at the free testosterone and the sex hormone binding globulin. That's going to be important. Let's say you've got a patient who presents with low testosterone symptoms and you do a serum test and you only look at testosterone and it seems to be adequate. You're not sure why they're walking around with these low testosterone symptoms, but you didn't measure the free testosterone or that sex hormone binding globulin, which does what it sounds like it does, is it binds up that testosterone and renders it inert. So remember to get all three of those when you're looking at serum testing of testosterone. Mentioned follicle stimulating hormone and luteinizing hormone, things like prolactin, cortisol, great for assessing, somebody's in a disease state, maybe somebody's got some inappropriate lactation going on. First thing you're going to look at is like, is their prolactin level high? Perhaps they have a prolactinoma going on in the pituitary gland or, with cortisol. Serum's best for looking at disease states like, Addison's disease or Cushing's disease. You're not going to use serum cortisol testing to assess adrenal function or HPA active function. Doesn't give you that diurnal measurement. And also, I don't think anybody enjoys phlebotomy. Of course, if you're about to go and get your arm stuck with a needle, that is absolutely going to spike your cortisol and give you a falsely high measurement. So don't use serum hormone testing to assess adrenal function. Use salivary or urinary testing. It's a much easier way to go about that. But remember, keep it in mind if you're really concerned about extremes in cortisol levels, such as you'd see in Addison's or Cushing's disease. Okay, on that note, let's talk about monitoring testosterone in serum. So most labs have a very, very wide range in which, everything is considered normal. So a lot of times it's around 200 up to around 1500. Now, my complaint about this is that it's really not a level playing field, right? Like, should an 18-year-old have the same, should they be in the same range as a 70-year-old man? No, they shouldn't, because there's an age-related decline in testosterone. So we need to be able to kind of compress this range and apply it more appropriately to specific ages. Now, with women, that range is a lot shorter or smaller. It's 15 to 70. That makes a little bit more sense to me. But and I'll get to the reason why this range is so wide in a second. But also wanted to add a little news flash here is that Vibrant is now reporting testosterone levels up to 3,000 nanograms per deciliter. Now, this is important for your patients who are on testosterone replacement therapy. Very easy for them to get up over this, that 1,400, 1,500 range. So with this increased range that we've got, you're going to be better able to assess your dosing of testosterone in those people. So keep that in mind. That should be coming out any day now, actually. Okay, so let's talk about ideal testosterone levels. So we know there's an age-related decline in male testosterone production. It's kind of surprising that young men are evaluated with the same cutoff of 300 nanograms per deciliter that was developed from samples of older men. So I found this excellent graphic from the Journal of Urology based on their own studies. And so you can see we've got some more specific age-related ranges for men of varying ages here. So this is a great resource. I like to use that. So keep that in mind going forward for adequate levels of testosterone with your male patients. Now, and you'll notice back in the slide, it only goes up to 40, 44-year-old guys. What about the rest of us, the older guys? So I dug around and found these other ranges from various sources. Now, the problem is that there isn't the one be-all source that says this age of a man should have this level of testosterone. And the reason, still you're seeing here that these ranges are quite wide, right? You've got 50-year-old men, anywhere from 250 to 950, very wide range, right? With an average of 546. Now, the reason for this is just that testosterone ranges that widely in men. And so this presents a treatment challenge for you, because in my practice, in my experience, I've had a lot of guys come in with symptoms of low testosterone, and then I'll measure their testosterone and they have adequate levels. And I'll see the opposite too. Guys who don't really have any symptoms of low testosterone, but will measure it just as part of that overall wellness check, and they're down in the dumps. So it's very difficult to correlate those testosterone levels with symptoms in men. But take-home message with this is that we've got some tighter ranges here that you can incorporate those and keep that into consideration when you're helping and diagnosing your men. Certainly better than looking at that range of 200 to 1500. It's way too wide. So keep that in mind going forward. And also remember, do it in serum. Look at that free testosterone and that sex hormone binding globulin as well. Now, when should you start looking at testosterone in your male patients? Well, a man's testosterone levels starts to decline about 1% annually starting in their 30s, so pretty young. Whereas women they're moving along just fine, and then their testosterone levels start to decline at menopause. So a little bit of a cruel trick of nature. Guys' testosterone declines as we age, whereas women's testosterone increases as they age. Now, what are those symptoms? What I call, poor or low vitality. So kind of a combination of, lack of drive, lack of motivation, lack of libido. They're just, they just don't have that vitality for life. Depressed mood is common, irritability, especially in men. So a man who kind of has become more irritable over the last year, no real changes in life, absolutely you want to measure those testosterone levels. Also, low energy, poor endurance and recovery. I'm not talking about athletes here necessarily, but think about most of us, men or women, we come home from the work week and we're probably pretty excited about doing some projects around the house, or maybe going skiing, or maybe going on a hike, or doing something with the family. So when a person says, oh, I just don't have any energy, I need all weekend to recover from my job, the job hasn't changed, the job maybe isn't necessarily physically demanding. I get it, there's different situations where you might be pooped out all weekend, but nevertheless, if somebody's ability to recover or their endurance is decreased, that's also a kind of a key symptom of low testosterone. And then another one, pretty insidious, is declining muscle mass and increasing body fat. This is a normal progression as we age, and I put normal in quotes because it doesn't really have to occur like that. This is definitely a kind of a direct casualty of low testosterone and also a sedentary lifestyle. But again, people will present with saying like, geez, I've just lost muscle mass for some reason. I don't know what happened, and I've gained more weight. Definitely testosterone should be part of that workout for them. Okay, so what lifestyle factors lower testosterone? There's a lot of them. So in men, the reproductive system consists of the hypothalamus, the pituitary, and the testes. Now, of course, the hypothalamus is part of how we interpret what's going on in the world. If somebody is in extremely high stress, they're in chronic fight or flight, that signifies to the brain that this isn't a safe time to reproduce. So that is going to drive that testosterone down lower. Now, alcohol is a big one. It interferes with the function of each of those components, the hypothalamus, pituitary, and the testes. So when somebody's imbibing in too much alcohol, you're going to end up with impotence, you're going to end up with infertility, and even reduced male secondary sexual characteristics. So as an example, in the testes, alcohol adversely affects the Leydig cells, which produce and secrete testosterone. Definitely, we know that heavy alcohol consumption lowers testosterone levels in the blood. Also impairs the function of the Sertoli cells that are also in the testes, and those cells are responsible for sperm maturation. So, and then in the pituitary, alcohol can inhibit the release of luteinizing hormone and follicle stimulating hormone, which directly stimulate those Sertoli and Leydig cells. So long story short, too much alcohol is not good for anybody who's struggling with testosterone issues. So that's a big one to bridge, because getting people to cut down on alcohol can be challenging enough as it is. Other issues, poor nutritional status, so low vitamin D, low magnesium, low zinc, inadequate protein. These are biggies for adequate testosterone production. Now, you can assess these levels using our micronutrient panel. It'll look at various a handful of amino acids where you can extrapolate protein intake, and it'll definitely look at these other 3 nutrients. Now, keep in mind, we also have the NutriPro test. And the NutriPro, I kind of put, is the micronutrient test on steroids, because not only do we measure all the micronutrients, but then we're looking at the genetic SNPs that are going to affect how you are going to absorb those nutrients. So as an example, let's say you run a vitamin D on somebody, they're low, you supplement them with vitamin D, you retest, they still have not, the levels have not improved. That's when you want to look at that NutriPro, because they probably have that SNP that is inhibiting their ability to absorb that vitamin D. So keep that one in mind for nutritional status. Of course, sedentary lifestyle, not using the muscles, of course, leads to decreased muscle mass. So when we use the muscles, when we do strength training, lifting heavy things, as I put it, that has a direct effect on testosterone secretion, so especially those larger muscle groups. So in my practice, I try to get everybody to engage in a strength training program, no matter how old they are. That's super important. So I hope you will do the same in your practice to help these people support their testosterone levels. Now, lastly, sleep deprivation, both acute and chronic, can inhibit testosterone production. Even as little as 5 hours of sleep a night can lead to a 10 to 15% reduction in testosterone levels the next day. So watch out for that. Of course, we're all, none of us are immune to a poor night's sleep, but if it's going on for a long time, obviously sleep is how we recover. So that's going to be an important part of that overall health and longevity plan, is to get people sleeping better at night. Okay, so let's switch gears into salivary hormones. Now, primary benefit of salivary testing is that we're looking at the steroid hormones that are collected from saliva. These are unconjugated or bioavailable, rather than those total or protein-bound hormones that we measure in the serum. What that means is that we're capturing those hormones that have detached from those carrier proteins in the bloodstream, exited the bloodstream, gone into the tissue, and have done their work, and now we're capturing them in the saliva, which is one of the avenues of exit from the body. You can do this at home. Obviously, it's very convenient in that regard. Remember what I was talking about cortisol before. There's obviously no needles involved. So looking at salivary hormones is a much better way to assess cortisol hormones. And again, you're getting that diurnal measurement, so you're getting that measure 4 times a day. To really tell you what's going on with the adrenals and or that HPA axis. And then, these can be collected at any time, generally speaking, any time of the day. For men, obviously, any time of the month. But for women who are menstruating, you definitely want to target day 19, 20, or 21 for collection of salivary hormones, keeping in mind that day 1 is the first day of her most recent period. So start counting on day 1, and then pick day 19, 20, or 21 to get an accurate assessment of those female reproductive hormones. Okay, now here are the hormones that you'll see. We expand it. You're getting the other estrogens. These are the 3 main estrogens: estrone, estradiol, and estriol. We're looking at a couple of important ratios here. This is the estrogen quotient. And then we're looking at the progesterone to estradiol ratio, which we can assess whether they are progesterone or estrogen dominant. And then again, the biggie are the diurnal cortisol patterns. And then again, we can measure testosterone and DHA, a couple of the androgens in the saliva. Nothing wrong with doing that at all. Personally, I just prefer using serum in addition to the saliva test to get a better picture of the testosterone. So you're starting to see different utility for different tests here. Okay, this is an example of a summary page for the salivary hormones. So you'll see this is a relatively simple one. This person didn't have a whole lot of out of range. If you've done some of these hormone consults with me, you know that I don't necessarily spend a lot of time on this summary page, because you're just seeing everything that's out of range. And personally, I like to look at one particular hormone in association with its similar hormones. So example, looking at all the estrogens at once, all the progestrogens at once, et cetera, et cetera. So this is what the rest of that report will look like. So this is what I'm talking about. Okay, this is a lot easier way of looking at all those estrogens, and that just helps me kind of form the big picture in that regard. Now, when should you start looking at estrogen and progesterone using the saliva test? So very generally speaking, progesterone begins to decline very slowly in a woman's 40s, whereas that, estrogen stays put until menopause happens, when it drops very precipitously. So typically you've got that estrogen level that's staying at one level, and that progesterone begins a very long, slow decline. So a lot of times these women end up being estrogen dominant, and we can see that on this test. But symptoms most commonly that I see are things like dysmenorrhea, heavy periods, irregular periods. Maybe she's menstruating twice a month, PMS worsening. Maybe she'll say, yeah, I didn't really have a whole lot of PMS in the past, but now it's like out of hand. So changes in the menses, of course, things like hair loss, anxiety, and insomnia are the three biggies, really. You'll often see that before the period even changes, at least in my experience. When that progesterone declines, that anxiety increases, we get more insomnia, and then that hair also starts to fall out. So look for that combination there. That one's really important. And then you might also see some weight gain because of estrogen dominance, and sometimes even hot flashes and night sweats because of that. Vasomotor instability starts to happen when those two main hormones get out of balance. So general rule of thumb, obviously, anytime somebody comes in symptomatic, but you're going to see a lot more of these symptoms in somebody's 40s. So 40s for estrogen and progesterone. And then if you're dealing with a guy looking at testosterone, you might start testing these guys in their 30s, generally speaking. Oh, I skipped one. Okay, so let's talk about that progesterone to estrogen ratio. So this was it's been used empirically as a marker of estrogen dominance. This is developed by the late John Lee, MD. So we'll also use this in relation to IVF and fertility, et cetera, et cetera. But you can have, so the progesterone to estrogen ratio, if it's increased, that's almost, so that means they've got more progesterone to estrogen. That's almost always caused by exogenous progesterone use, at least in my experience. So progesterone creams, believe it or not, are available over the counter. That's okay, but the problem is that when people decide to go use this themselves without knowing the accurate amounts or dosing or testing, they often present in the clinic with symptoms of excess progesterone or progesterone dominance. So that can look like, feeling drowsy, dizzy, having a headache, weight gain, bloaty, things like that. So definitely, and progesterone is also hyperthermic. So if somebody is using progesterone a little too much, more than they need, they might feel like they're hot all the time. And if you don't test them, you might assume that they've actually got an issue with estrogen when it's in actual excess of progesterone. So keep that in mind. That's progesterone dominance. More rare in my experience, but of course it does happen. Whereas on the other hand, if you've got a decreased progesterone to estrogen ratio, then we're talking about excess estrogen relative to that progesterone. So this is estrogen dominance. And again, that is going to be common with, these women who I described who are in their 40s. Progesterone has begun to decline, estrogen has stayed the same. They're now estrogen dominant. So they are also maybe going to present with some vasomotor instability, those hot flashes, those night sweats, and those symptoms that we talked about before. So this is a really handy ratio to look at in that regard. Okay, now let's talk about the estrogen quotient. This is what we're talking about is the ratio of estriol to the sum of estrone and estradiol. Now this equation was popularized by Henry Lemon. So he was a breast cancer researcher. And this kind of refers to the concept that a higher ratio of estriol relative to the two stronger estrogens has value in both prevention and outcomes in breast cancer. So with his research, Dr. Lemon's research with female patients, he found that, the optimal ratio was 1 or 1.5 was optimal. Now, keep in mind with Vibrance test, our reference ranges for this are based on the average values of the samples in our test validation cohort. So we're not necessarily going to use that same ratio that Dr. Lemon does here. So keep that in mind, but you can use that if you're interested in that. Remember, 1 is ideal, 1.5 is optimal in regard to that estrogen quotient. So I like this, again, this is a great way to assess risk. Again, extremely common, vast majority of women presenting in clinic are going to be estrogen dominant because of, again, how that progesterone declines, and also because of all the environmental estrogenic influences that we all come across. Also, adipose tissue, unfortunately, people gain weight. Oftentimes, as life goes on, adipose tissue can be a really important generator of estrogens. So also keep that in mind when you're reviewing this test. Okay, so let's switch gears again, like I promised, and then let's talk about the Pregnenolone steal. Now, if you haven't heard of the Pregnenolone steal, this is a theory that's been around for quite a while now, stating that high stress leads to an elevated use of Pregnenolone for cortisol. So the body is essentially stealing Pregnenolone to create cortisol, and by doing that, we're short-circuiting the production of all these other hormones in this section. Now, it's a great theory that a lot of us subscribe to initially to explain why, why we have these depleted DHEA and other hormones like progesterone in instances of high stress. But fortunately or unfortunately, this has been disproven. There is no known adrenal pool of Pregnenolone that one cell would steal away from the other, and there's no known mechanism that's been described that can facilitate the transfer of Pregnenolone between the mitochondria of different cells. And then kind of this happened, unfortunately, the most common figures used to teach steroidogenesis like this one make it really easy to come up with theory like that. But nevertheless, there really is no such thing as the Pregnenolone steal. Like I said, interesting theory, but that's kind of been fallen by the wayside these days. So just a little bit of an FYI to you. Really what happens, people get stressed. There's many environmental influences that ends up short-circuiting the production of these hormones, more so than some kind of like biochemical weakness like the Pregnenolone steal describes. Okay, let's talk progesterone and saliva hormones. So in regard to using transdermal creams like progesterone, it's been consistently shown that serum, whole blood levels always underestimate tissue levels of hormones or following the use of transdermal hormones. So basically what I'm telling you is that saliva is the ideal method to assess topical progesterone use if you're going to prescribe that. If you give a person topical progesterone and you're looking to assess those values in the serum, it's just not really going to reflect adequate levels of that going forward. So use saliva in cases of topical progesterone dosing when you prescribe that. So that's another reason to use that saliva test. Okay, then we've got this cortisol and cortisone summary page. And essentially, most of us are familiar with cortisol. It's a stress hormone. It's released when we're under stress. It should be highest in the morning, generally speaking, and it should trickle down throughout the day. Now, when I say high in the morning, I don't want anybody looking like this. This person had some caffeine or some very high stress that day. So generally speaking, higher in the morning, decreases throughout the day. And then this cortisone is the deactivated or inert form of cortisol. So theoretically, these two graphs should approximate each other because as you're making cortisol, if it gets too high, then you're going to shunt that over. You're going to deactivate it and make cortisone out of that. So the body does that to protect the mineral corticoid receptors from excess cortisol stimulation. So it's kind of our built-in safety. So those two graphs should generally look the same. Now, why would they be different? Well, if your cortisol is much higher than your cortisone, one, it can be just from very, very high stress. Maybe somebody woke up on the wrong side of the bed. Maybe they had too much caffeine. That could happen. Also, exogenous use of hydrocortisone. Drugs like furosemide is an 11 beta hydroxysteroidogenesis inhibitor. And then things like phthalates, organotoxins, and PFAS, or peri and polyfluoroalkylated substances, can inhibit that 11 beta enzyme. So if you see something like this on the test, this is where our total tox test might come in handy. You can measure the phthalates, the organotoxins, and the PFAS as a separate test, but maybe consider looking at the person's environmental toxins load. Now, if their cortisone is higher than cortisol, this can be, due to very high, stress. They've produced a lot of cortisol. It's been shunted over into the cortisone. Of course, normally the kidney will deactivate that cortisol, and then, or that patient may be on ACE inhibitors, and that will inhibit that other enzyme that's responsible for the conversion. So just a few little tidbits on why those might be different. But of course, we're measuring cortisol, we're measuring that diurnal cortisol pattern to assess, that HPA axis and how that adrenal gland is responding. And generally speaking, in my practice, I'm looking at a diurnal cortisol just to make sure that people are able to mount a normal stress response that isn't through the roof. When it's very high, then we're looking at a possible cause for weight gain. Cortisol is a storage hormone also. Kind of think back when we were wandering around on the savannah or the plains and we had an accident or some stress, you would release cortisol because that was going to help us store fat and keep us nourished if we were unable to move and get food. So weight gain and also insomnia are big ones with cortisol. And if you're not sleeping, cortisol is going up and further contributing to that weight gain. Okay, let's switch gears into urine hormones now. So with urinary hormones, we're looking at the parent and metabolites of those hormones. So this is a great way to assess that risk that I was referring to earlier and how we can mitigate that risk. I kind of refer to urine hormone testing as the who, what, when, and where of hormone testing, because we're really seeing all the hormones and what's happening to them. And, are they going down a healthy pathway or are they going down an unhealthy pathway is important. So, of course, no needles. Again, the great way to look at those, the diurnal cortisol patterns also. So we're going to look at, this is the most complete hormone test. Definitely useful on its own. That's definitely useful with the other tests too. A lot of practitioners I speak with end up using saliva and urine just to get, the big picture. But overall, if you're worried about somebody's risk of reproductive cancers, this is the one to use. Now then, we are able to measure numerous metabolites, numerous estrogen metabolites, androgens, progestogens, corticosteroids. And again, this is all just because we want to see, how, yes, are they making hormones? And then what are they doing with those hormones? Again, hormones are the fountain of youth for us. We need them for our vitality and our health, but oftentimes when we are prescribing hormones or supporting hormones later in life, it does come with some degree of risk because these tissues or because hormones can lead to other, toxic effects in the body. We'll leave it at that. We also look at melatonin and then also 8-hydroxydeoxyguanosine. This is an excellent marker of oxidative stress. So I like to look at that one too, because of course, oxidative stress combined with maybe the improper downstream metabolites of those hormones can lead to reproductive cancers or other negative outcomes like that. So that's an important analyte on this test also. Okay, again, here's a urine hormone summary page. So you can see that it's very busy. Again, if this were your test and you pulled this up, it's like, wow, there's a whole lot of red on here. So again, just quick assessment. Yep, there's a lot going on, but then let's go look at each hormone with its family of compounds. So here's what the estrogens look like. Again, it's just easier to see what's happening, and a lot easier to pick up the patterns when you look at the individual panels like that. Now, let's talk about some urinary estrogen basics. So we're looking at, when we measure the urine hormones and we're looking at the estrogens, we're looking at phase 1 and phase 2 metabolism and those metabolites. So just a quick review: phase 1 metabolism, it's an oxidative process, involves hydroxylation. We're rendering these metabolites, we're rendering them hydrophilic, so they're water soluble, so they can get out of the body, taking them away from their lipophilic, right? Because these are based off of cholesterol, so they're more fat soluble. So making them more water soluble. Estrogen metabolites can be produced from hydroxylation at the 2, 4, or 16 carbon of the steroid ring. And then we will name those, that we'll have we've got a 2-hydroxy pathway, a 4-hydroxy pathway, and a 16-hydroxy pathway. And we'll see those metabolites here momentarily. And then, so we can make this kind of general statements about these. The 2-hydroxy metabolites, these are considered safer regarding potential for harmful intermediate production. These metabolites have reduced estrogen receptor affinity. These are metabolites that can inhibit breast cancer cell growth and proliferation. And just a general preponderance of 2-hydroxy metabolites is associated with reduced breast cancer risk in relation to these other ones. Now, 4-hydroxy metabolites, these are generally considered unfavorable. These are easily oxidized to DNA, damaging quinone and semiquinone conjugates, which then react with DNA, lead to mutations that can initiate cancer. And then these metabolites, a preponderance of these metabolites is significantly associated with breast cancer risk and premenopause and prostate cancer in men. So there's that. And then we've got the 16-hydroxy metabolites, which are just considered unsafe. These have a strong estrogenic activity and an increased risk of breast cancer. So how do you memorize all of that? Well, let's hold that thought ahead of myself, but let's talk about the phase 2. So we just talked about phase 1. Now all these metabolites will go into phase 2. This includes methylation, sulfation, glucuronidation, glutathione conjugation. So we're looking at moving these, these hydroxylated compounds into methylated compounds. So phase 1, phase 2. On that note, we've got a really excellent environmental toxin detox guide that will help you understand phase 1 and phase 2, and then methods you can use to enhance that. So just overall detox, and also if you've got an excess of certain unfavorable metabolites, then you can address, do they need to be in phase 1? Do they need to be in phase 2? And also, of course, working on elimination. So these are the methylated compounds that you'll see on the test. So that's methylation is generally more favorable than hydroxylation. You can hydroxylate things and they can still hang out, but they've got to be methylated to move on out of the body. Now, again, here's where I was talking about before. How do you memorize all of that? 2 is better than 4 is better than 16 is how I can remember these things. And then methylation, generally speaking, is better than hydroxylation. But keep in mind, you wouldn't stimulate or turn on hydroxylation and not do anything with methylation, right? It's a 2-step process of transforming these and getting these out of the body. So long story short, make sure you're addressing all of the detoxification pathways. Now, just because it's in red doesn't mean it's unfavorable. Going back to that summary page, like you will see some compounds that turn red. That may be because they're low, or sometimes you'll see an excess of, say, a 2-methoxyestradiol, which would generally be a favorable thing. So again, you've got to parse through looking at the actual values in comparison to their reference ranges. Now, again, on that test, there's a lot on there. Any metabolite that is out of range, comments are going to populate, and the comments are pretty straightforward and specific. So that's a great way to understand whether this person has a favorable ratio of different metabolites on there. And then, I'm always looking for patterns when I'm reviewing these. And like I said, we're going to often end up supporting phase 1 or phase 2 or both of those phases on there. And of course, as you start to order these, hook up with one of the clinical lab educators here at Vibrant. We can walk you through that and help you understand that. And then you will be good to go. So here's what I was talking about with the estrogen comments. This person has a low 4-methoxyestrone to 4-hydroxyestrone. So they're not methylating this estrone very well. So that's why they're low there. But this will explain this for you. So all the comments are excellent on this test. And then all that being said, we do have a salivary hormone interpretive guide, and then we've got the urinary hormone interpretive guide. These are excellent resources for you. They're many, many pages long. They're like a book in themselves. They're on the educational portal. And then if you happen to do a consult with one of us, we can easily mail that off to you as well afterwards. Okay, and then let's quick gears and start wrapping up here. But let's talk about those cardiometabolic markers. Now, these panels are under Vibrant America. Check out the diabetes panel. This is going to include things like glucose, hemoglobin A1C, glycated serum protein. It's like a similar protein to hemoglobin A1C, looking at the long-term burden of sugar in the bloodstream. We look at adiponectin. This is a hormone that your fat tissue releases to help with insulin sensitivity and inflammation. Low levels of adiponectin are associated with several conditions, metabolic conditions, like obesity, type 2 diabetes, atherosclerosis, etc. We're looking at insulin, of course. High insulin drives testosterone production in the ovaries and lowers sex hormone binding globulin. So that can result in estrogen excess, increased visceral fat, leads to raised cytokine secretion of pro-inflammatory cytokines like leptin, so estradiol and insulin. So a lot of good reasons to run that diabetes panel. I run it on everybody that comes in, whether they're diabetic or not, right? Because again, we're looking for prevention and wellness and making sure that they're metabolically fit in that regard. So like I said, I run this on everyone early and often. This is just a primary lab that I'll run and repeat that one. Blood sugar dysregulation, it paves the path for hormone imbalance. This is where it all begins. We've got aging, age-related hormone dysfunction. Generally speaking, in my experience, the people who have maintained healthy glycemic control over the years have less hormonal dysregulation with aging. So that's why I say it paves the path. And then, like I was talking about, remember that insulin, when insulin is imbalanced, when insulin is elevated, that also paves the path for reproductive hormone imbalance too. So check this one early and often, like we said. And then the cardiac health panel. Well, let me back up too. This is a very inexpensive panel. It's like, I think it costs $27 to run this. So no reason not to get this done on all of your patients that come in, or really everybody needs this test. Now, sorry, I got a little out of balance here. Okay, so, the cardiometabolic panel, or further cardiometabolic markers, cardiac health panel. So we're looking at lipids and 5 inflammatory markers. So plaque, homocysteine is a metabolic byproduct of methionine production. This is atherogenic. Of course, oxidized LDL. This is an excellent test to look at. Yeah, maybe you've got high LDL, but none of it's oxidized. Of course, the oxidized LDL is what contributes to atherogenesis or atherogenic disease. MPO, myeloperoxidase, that's a leukocyte-derived enzyme that catalyzes the formation of reactive oxidative species. Plaque, phospholipase A2 is the other name for this. This is also a marker of inflammation in the lining of the arteries. And then, of course, we've got high sensitivity CRP. So again, this is a, just looking at the inflammatory markers alone costs like $45. So this is the best method that we have at looking at non-specific inflammation in the body and in the bloodstream. So because again, if you've got somebody with elevated total cholesterol, maybe it's 250, something like that, and they have no inflammatory markers, then of course their risk for heart disease is going to be very low. Whereas somebody may have very healthy, quote unquote, healthy lipid panel, normal cholesterol, normal LDL, HDL, but their inflammation is through the roof. That is a recipe for heart disease. So definitely check this one on all of your patients as well. Now, I want to point out a little bit of a segue here, but this is an excellent video by Rhonda Patrick, PhD. It's like 30 minutes long. You can watch it on your lunch break. She goes into a succinct and deep dive with excellent graphics about intestinal permeability, lipopolysaccharide, and cardiovascular and neurodegenerative diseases. So long story short, when we have permeability in the gut and an overabundance of gram-negative bacteria, which of course you can measure on the both the wheat zoomer. The wheat zoomer has an intestinal permeability panel, and of course the gut zoomer will tell you about the preponderance of gram-negative bacteria. But nevertheless, when we have leaky gut, we're leaking LPS into the systemic circulation. The LPS in circulation contributes to atherosclerosis. LPS binds to small, dense LDL, and it's not really well absorbed by the liver. And then it can get deposited in the lining of the arteries. And of course, then the immune system thinks that LPS is bacteria, right? Because that's a signaling molecule, so to speak, on the bacteria. Tries to phagocytize it. This is what creates foam cells, leads to atherosclerosis. Of course, LPS can also break down the blood-brain barrier too. So kind of a long-winded pathway there, but check the gut zoomer, check the wheat zoomer, which contains that intestinal permeability panel. That way you can measure gram-negative burden and LPS burden and see if they're reacting against it. And remember, long story short, too much LPS can contribute to cardio and neurodegenerative diseases, which is, of course, a huge part of controlling for and mitigating and assisting people to age healthily. Okay, so just kind of wrapping things up here, hormones and healthy aging, test early, like we were talking about, start looking at testosterone probably in the 30s for guys, early 40s, female reproductive hormones, estrogen and progesterone for sure. Of course, both sexes need to have a look at all those other hormones that we talked about. New patients, I will measure, test every 3 months while we're getting things adjusted and monitoring. And then once we have that accomplished and people are feeling good, then, I'm not waiting another year, especially, in the, whatever we want to call it, the over 40 crowd, things can change more quickly than you would catch in just an annual test. So I'm a little quicker on that every 6 or 9 months, because once things go astray and you haven't tested them, it's harder to get them on back up. So test them more often than a year. Then very quickly, just 4 pillars of healthy aging. I think we all know this, but I just want to drive this home again. Maintain and monitor that glycemic control. Remember, that's where things really start to go off the rails, is when this is out of control. And of course, this is epidemic in our country today, even in the kids. So that's really a big one that I drive home. Exercise has to be daily, needs to be strenuous, needs to be heavy things. So get your patients and your clients in the gym or at home doing something to stay exercised. I really truly believe this is the fountain of youth. And then also I have breaks too in here. So additional information, sadly or not, but yes, daily exercise is great, but now there's some research pointing that we need some exercise breaks too. So these are things like running up a flight of stairs or doing a set of push-ups if you've been sitting at your job all day. So that is an even better way to control your health. So keep that in mind in the middle of your office day. And that's one of the things we encourage people in the clinic if they're ever feeling sad or having a problem. That's our going joke. Why don't you try some push-ups? So exercise is important. Of course, measuring, balancing all those hormones. It's very challenging to start out with, but it's also super rewarding. So I'd encourage all of you watching to, if you're not already well educated in hormones, really do what you can to learn more about that, because this goes so far in helping your patients be healthy and stay healthy. And then, of course, stress management and neurotransmitter support is also very important too. Just like we tell everybody to exercise every day, everybody needs a stress management protocol as well, because stress is also that, one of those things that will just eat your health up if it goes unchecked. And then, we can also look at the end results of that stress by looking at one of the neurotransmitter tests, and that can also help us balance out the neurology when somebody's under a lot of stress too. So those diet, exercise, stress management, and hormone balance, they all need to be firing on all 4 cylinders for us to help people achieve their health. So with that, I'm going to finish up speaking, and now we're going to hopefully entertain some questions with our Q&A right now. All right. Hi there. Thanks for watching. I'm going to take a look and see what kind of questions we've got going on there. Will there be a replay? Yes, we are. This is recorded, and we will send this out to everybody that signed up, that registered for it. So don't worry about that. That goes for all of the webinars that we put on as well.